Thank you very much. And we'll go on to NHS Performance. Just on this paper to note that we are on this occasion bringing a single paper to the board, one which deals with the performance over the NHS as a whole, but the second, the performance of NHS England and supporting the performance of NHS overall. So I'm going to invite Barbara, please, to kick off.
Thank you, Chairman, and then I'll hand over to Karen for the second part. My report on NHS Performance follows the standard format, and what I won't do is repeat some of the things I've raised in previous meetings, but I have a number of issues that I particularly want to highlight out of this report. First, I would like to just reiterate that it shows just across the board how busy the NHS is, but how well staff in the front line of NHS is doing to deliver to patients the services and the standards that we all want to see. Just a reminder that the standards or targets are how we measure ourselves in the NHS to ensure that we're delivering to patients their constitutional rights for those sections which are about the Constitution. But I think it's always important to keep this into perspective. Our constitutional rights, by constitutional rights, if we look at A&E and the number of patients who are admitted or discharged within 4 hours, in order to give ourselves assurance that we're meeting the standard, then we look for 95 out of 100 or 950 out of 1,000 patients to actually have their constitutional rights delivered and be admitted or discharged within that 4 hours. Whilst it's always disappointing when we don't meet the standard, I do think in perspective what we need to realise that whilst we're not meeting the 950, 925 out of 1,000 patients are getting their treatment within that time. And actually the vast majority well within that 4 hours. The vast majority of patients are only there for an hour or so. So I think on all of these it's important to keep in perspective for what is a very important thing we do to measure our own success, but actually making it very clear that for the most part, the vast majority of patients do get their treatment in the times that have been set down within the constitutional standards. I'll also just highlight that since we wrote the report and was published on the website, the September figures have been published. Disappointingly, across most of the standards, they show a small reduction. But for the most part, you know, the figures in here are a fair and true reflection, because as I say, the changes in the September figures are small. And then the third thing that the report highlights is just how much is in train, not only within NHS England, but within NHSI, so that the national bodies can support the front line, and particularly working with local authorities and social care to try and reduce the number of delayed discharges, which we know contribute to how well the NHS can deliver its services. So the report goes through the range of things we're doing with our partners at national level in order to help support CCGs and NHS providers of care to be the best they can be in delivering these standards. Finally, Chairman, if I can, could I just update the board, as Simon mentioned earlier, that in line with NHS England's statutory duty to manage emergencies and major incidents, we are in NHS England through the emergency planning team coordinating the preparation for any action which ensues by junior doctors, just in order to ensure that the best possible services for patients and patient safety can be maintained.
Thank you, Barbara. And of course, that's something that the board will want to follow very closely indeed. But we take your assurance, but we know that the current circumstances are uncertain. May I invite questions or comments to Barbara before we turn to part 2 of the report? No, well, thank you very much, Barbara. Karen.
Yes, thank you. On the NHS England performance report, the main element of this report is the dashboard of progress against business plan priorities. So this is essentially rating us against our ability to deliver what we committed to deliver at the start of the year through the business plan. The annex also, just in case it's not clear enough, on the right-hand side of that table, the dashboard table, reflects GMPP and IPMB, which are basically major programs and informatics programs, in addition to those which are subsumed within our overall priorities. These programs are effectively a subset of, in many areas, a subset of the 5-year forward view delivery plan, but obviously don't include all of the 5-year forward view, and in some areas concentrate on NHS England performance as well as wider NHS. So they are big and complex. And it's also worth pointing out that some of these programmes, although we are monitoring progress against our delivery for this financial year in here, some of these programmes are, of course, 3, 4, 5-year programmes, and will take that amount of time to fully deliver. They're in very different stages. Some, for example, we talked about urgent and emergency care and learning disabilities. Some have been going like that for some time and are well established and absolutely into delivery. Others are in relatively early stages, cancer, mental health, where the programme's at the stage of transforming strategic proposals into a delivery plan, which will then be costed. And some of those obviously will be impacted, the delivery of all this will be impacted by spending review allocations as well, which will doubtless be taken into account. So they are in very different positions. We have just wanted you to be aware that these ratings reflect both delivery to plan and, as what I tend to call, inherent risk. So some of these, where we've got amber red, does not necessarily mean that they are not failing against the delivery plan, but rather that there is a huge amount of inherent risk associated with them, and so I think that's worth noting. We are currently doing a stock take of all of our business plan priorities, and that will refresh this dashboard and give us a more up-to-date view and a more in-depth view. I think the stock take and the way that we're governing the priorities has actually been really helpful in terms of making sure that the whole organisation is pulling behind each of these priorities. It's not just a directorate-owned piece of work. And the stock take is certainly identifying, good governance and good process, and in many areas the programmes are well established. Probably the two areas where we're not as good and we need to do more. Some of them is there are capability issues, both in programme management and aspects like commercial procurement expertise. So we are putting in place improvements to improve that for a number of programmes. And secondly, costed delivery plans, which as we go into our business planning process for the next year, we are asking all of the priorities to work out their 3-year costed delivery plans for these programmes. That's something more work needs to be done on to give us assurance around all of that. So those are the priorities. I wasn't going to talk about the risks. Clearly the risks are a mix of programme change and also operational delivery. I wasn't going to talk about those in particular, and there is a third element of our corporate performance which isn't reflected in here, but I wanted to assure you of, which is we also, of course, scrutinise and look at our own corporate performance of services. There wasn't anything to bring to your attention here particularly today, but I just wanted to assure you that we are all over that as well.
Thank you for the report. Let me invite comments and questions from the board. No.
I think Karen's done a tremendous job to organise huge complexity into what most people in the outside world would regard as a very structured transformation plan. But I note that in the stock take, Karen, you are also pointing to evidence that there is delivery risk, but also potentially delivery delay as well. what is the best way for thinking about how to manage progress of this huge complexity, given that we're only at the start at the moment, and over the next couple of years it's going to get more complex as we get into delivery? What would you anticipate the stock take coming up with recommendations on how we're going to provide some sort of umbrella overview of progress performance?
So very, very good questions. And yes, for some of these programs, of course, now they are into, we heard about urgent emergency care, learning disabilities. These are system changes that need to happen out with the system. They are not within our direct control. This is going to be very much a partnership of working with local systems and so on. These are a subset of the 5-year forward view. The 5-year forward view, of course, has a series of programmes as well, which are responsibility of other arm's length bodies, NHS Improvement, Health, Education England, and so on. So part of the challenge around this area is being really clear what's NHS England, what's 5-year forward view, how do those two dock together, and how can we work with our colleagues in other arm's length bodies to ensure that we are working on all of those together. So I'm talking, obviously, I mean, Ian leads on a large part of this on the 5-year forward view. Joe Lenihan works supporting the 5-year forward view overall governance as well, so that we can, I think, try and create an overall delivery plan which takes account of our work in the context of the 5-year forward view. I think that's really quite important. It's all part of the same work, and we need to be able to be clear how our progress is reporting under that. So joining up the governance, sharing information, creating an overall delivery plan, I think is a key part of that. Secondly, it is about capability. These programs are all about the capability of the leadership and the resources that you put into the programs, whether it's program directors, whether it's SROs, or national implementation directors, as we're trying to recruit. Very specific capability, as I said, around procurement expertise and so on. Some of those are quite scarce skills, so we are trying to recruit and improve all of those as well. And then there's a third docking, I suppose, with the 5-year forward view, is making sure that the work links into the business planning work for the wider system, so that local organisations across the NHS and wider system are not being asked multiple times for different things, but are building this work into their local plans. So again, we're trying to make sure that our own work here docks into the planning guidance which we give out to the NHS, and that builds into 3-year forward plans for local systems as well.
And if I may just make an additional observation, Malcolm, I mean, one of the many lessons learned from complex transformations in organisations outside of NHS England is the falling into the trap, or the risk of falling into the trap, that when we divide the world into silos, because silos are very good for executing in this way, actually we kind of assume the silos will get on and do it. Yeah. And actually, when we do divide the world into silos, we need to put as much emphasis on the horizontal cross-cutting linkages between silos, which has, in the past been hugely forgotten and ended up tripping up the process of delivery much later on. So it's purely an observation, and one we'll come back to, I know, but I think that is the other dimension of this world, which is how we join up from the patient standpoint, the receiving entity of a local health economy, right the way through to all of our organisational entities. They, in a way, need to see it as a joined-up delivery of outcome. as opposed to a series of 25 powerful silos. You'd agree with that, wouldn't you?
I'd completely agree with this, and where much of this, of course, lands is in the local health economy, and the local health economy need to probably not see urgent and emergency care and mental health and cancer and learning disabilities. They need to see a single plan for their local health economy, which is aiming to deliver the sorts of outcomes that we're looking for here, but which is their plan and which is joined up. So our challenge right now is making sure that we can articulate that well in a helpful way for local health economies, rather than confusing them with lots of different siloed plans. But so we're on it. I'm not sure we've quite got the solution yet.
It's
but
a journey.
Working on it.
Yeah.
Right, well, okay. I don't detect any other... oh, yes, I do. I'm sorry, Moira.
I just wanted to ask, given that child protection information sharing is showing as amber red, whether that was a delay or, as Karen said earlier, inherent risk.
Did you want to
actually,
pick
I
this
think it
one
might
up,
be
or-
an administrative issue.
So I think there is a risk. There has been a risk there associated with the system.
It's the speed of rollout.
Yeah.
It's the speed of rollout as opposed to the system itself. But we've just picked it. We've only just picked it up. So we've got a plan. We're looking at it at the moment. We've just taken it over, so we're looking at it at the moment. But we've increased the level of risk associated with it, having reviewed where we've got to. But we have a plan, so we'll come back with a plan to let you know. Good.
Okay, thank you. I think we've had a good review. Thank you, Karen, for the report. And as we know, that the priorities and programmes will change as we go through the next business planning round, and we would expect to bring that back to the board either at the next meeting or the following one.